I'm Dr. Tim Hannon, and this presentation is on reducing waste and advancing high-value care. With regards to CME disclosures, I am a consultant and the CEO of Healthcare Forward, a healthcare consulting company. Let's begin with the definition of high-value care. High-value care balances the risks, benefits, and costs of tests and treatments along with patient preferences. And all four of those things are really the goal that we should have anytime we either interface with a patient doing a test or a treatment. The goal then of high-value care programs is to enable clinicians to provide the best possible care to their patients while reducing unnecessary costs. Having defined high-value care, we can now move on to the definition of low-value care, which understandably is the other end of the spectrum. Low-value care involves the use of care that is unlikely to benefit the patient given the cost, alternatives, and patient preferences. And it's not insignificant. According to the Institute of Medicine, perhaps up to a third of the U.S. healthcare system is spent on low-value care, and there's a variety of components that would include insurance, regulation, pricing inefficiencies. But where we need to focus as clinicians is on the clinical sources of low-value care, such as the overuse of treatments, the overuse of diagnostics, and medical errors. The quote by Dr. Berwick also, I think, frames the issue well, in that we all know that we're under pressures to reduce costs in the systems, and waste certainly is the best, largest, smartest, and most humane way to be able to trim costs. So let's move on to what are some of the key sources of low-value care, particularly those ones that we as clinicians can impact, and we're going to focus on three fairly large areas. The first area, which may be familiar to many of you, is the overuse of blood products, which has fortunately been an increasing focus in the United States and globally through blood management programs. As you may know, blood transfusions are one of the most common procedures used in the U.S. healthcare system, particularly for hospitalized patients, which makes them certainly a logical target. We do know that randomized controlled trial evidence has consistently shown that transfusions are less beneficial and more harmful than previously presumed. At last count, I believe there are over 30 randomized controlled trials in various clinical applications. And in spite of that evidence, which continues to grow, we still know that blood utilization is far from optimal. In many hospitals, there is wide variation in transfusion practice internally as well as among hospitals doing similar procedures. And by some estimates, anywhere between 30 to 50% of transfusions are inappropriate or unnecessary based upon best available evidence, although I certainly hope, as I said, that those numbers are improving. Continuing with the conversation about why we should be focusing on blood utilization as a target, we should talk about the strategic significance. In other words, what's the administrative buy-in to focus on this particular area? And while blood products only constitute perhaps 1 to 2% of a hospital's budget, if you have a large hospital budget, that's a large number. We do know that blood utilization trends are evolving. For the most part, at least globally, we are seeing reductions in red cell utilization, but many hospitals are still struggling with platelets, plasma, and other coagulants. Transfusion costs are substantially more than the cost to purchase blood products. For example, the cost to test, store, and administer a unit of blood may actually exceed $1,200, even though you only pay maybe $200 to $300 to buy it because of nursing labor, lab labor, reagent supplies. And we know that the adverse effects of transfusions, which could include increases in hospital-acquired infections, complications that add to length of stay, could add another $1,000 a unit. It's also important to note that blood products are not reimbursed directly for inpatients. They're under a global budget and only minimally covered for outpatients. Moving on, what I believe is a second logical target for high-value care programs would be looking at the overuse of laboratory testing. Similar to blood products, laboratory testing is also a very high volume activity. In fact, it's thought to be the single highest volume activity, and it drives perhaps 60 to 70% of all medical decision making. That being said, studies have shown that there seems to be no good correlation between the volume of laboratory testing and outcomes, meaning more testing does not necessarily lead to better outcomes. And as such, we know that laboratory testing is highly variable among providers and across hospitals. And once again, the estimates for rates of overuse may be as high as 30 to 50%. So as you see, similar to blood products. There certainly are some patient safety and quality of care issues that are negatively impacted when we don't choose wisely, so to speak, for laboratory testing. One of the things that most people are somewhat familiar with is there's about a 5% chance in any given test for having a false positive. What that deals with is the normal reference range is set by measuring laboratory values like a hemoglobin level in a panel of healthy patients. And we know even for patients who are healthy without symptoms that there's a bell-shaped curve for the lab test results. So most laboratories draw the line at a 2 standard deviation difference from the mean, which means that even healthy patients have about a 5% chance of falling outside of that range. The significance of that is that the more testing that we do, the more tests that we do at any given time, the more likely we're going to get that false signal, those false positives. We also have to be concerned about either delaying or getting an incorrect diagnosis by not, again, appropriately testing, whether that's overuse or underuse. False positives can lead to overtreatment. Certainly the concern that plays into blood management is unnecessary phlebotomy. If we stick patients enough time for laboratory tests, we can make them anemic and need blood, and the issue of iatrogenic anemia then comes out. The strategic significance, again, continuing the conversation, laboratory costs you'll see are substantially more than blood costs and may constitute up to 5% or more of a hospital's budget. We know that laboratory test utilization and costs are increasing. In particular, reference lab testing is driving a lot of that growth. So most laboratories are reporting increases between 5 to 10% or more in their annual budget. And again, most of it being driven by specialty testing such as molecular and genetic tests. In the face of that increase in utilization, CMS, that's the Center for Medicaid and Medicare Services, is targeting $5 billion in reductions for laboratory costs. And that's sort of the pattern that we see for CMS. As they start to see increasing in costs in any particular area, they generally respond by trying to reduce reimbursement, which actually makes a bit of sense. So laboratory fee schedules may be cut by as much as 25% going forward. And we know that under capitation, such as accountable care organizations, capitated care or bundle payments, episode of care payments, we know are coming. All of these things are going to create even more pressures on reducing resources that are being used in patients, particularly when they're not adding value. The bottom line here is that at some point we're going to see a shift from hospital systems viewing laboratory as a revenue center, meaning they get more money to do more testing, no matter whether it's appropriate or not, to more of a cost center approach where they need to be thoughtful and only do the appropriate amount of testing. To round it out, the last major area that I see as an opportunity to cull out low-value care is imaging. And the story sounds very familiar to both blood utilization and laboratory utilization. Again, imaging is something we do quite frequently. A lot of activities that we do on the inpatient and the outpatient side involve imaging, which can range anywhere from ultrasounds to chest films to MRIs. Once again, in the literature, there seems to be no good correlation between the amount of imaging that we do in any particular patient and outcomes. There is plenty of evidence that says the use of imaging is highly variable among providers and across facilities. And once again, the numbers sound quite familiar. Estimates say perhaps 20 to 50% of the imaging that we do is not indicated based upon best available information. With regards to imaging, I think there's even more of a line of sight to safety and quality when we do inappropriate imaging for a couple reasons. The first one, which was somewhat surprising to me when I looked at it, is up to 31% of imaging studies will have false positives, which we call incidental findings. In the vast, vast majority of those cases, these false findings, these incidental findings, are not clinically significant, but almost always lead to further testing, which drives up cost, certainly drives up anxiety in the patients, and can lead to adverse events associated with it downstream testing. So significant. Remember, laboratory testing, perhaps a 5% false positives. It may be as high as 30% in imaging. The second thing is I have to remind myself and my colleagues is that ionizing radiation is not benign. Although it is a miracle that with a CT scan we can peer inside of the body without cutting it open, the fact is that when we do a CT scan as opposed to a plain film, we are delivering hundreds of times the amount of ionizing radiation. And in fact, some people have estimated that probably there's been a 6 times increase in the per capita radiation dose across the United States because of the advance and increased utilization of CT scanning, and that's since 1980. And by other studies, there are also estimates that perhaps 1 to 3% of annual cancers may be related to this increase in per capita radiation dose. So in addition to the issues of overutilization per se, I think there's some very legitimate patient safety reasons to add imaging to our list of low-value care targets. Again, the strategic side of this is that imaging accounts for a substantial cost within the healthcare systems, and now we're into the 11 to 15% range. We do know that these costs and utilization are increasing, particularly on the outpatient side and in our emergency departments. And for probably similar reasons that CMS is now targeting reductions in reimbursement for lab, they're doing the same thing for advanced imaging being primarily CTs and MRIs. So one of the things that they've done is under the PAMA Act, they are going to be requiring computerized decision support using appropriate use criteria for advanced imaging on the inpatient side, which is new and should be rolling out within the next year or two, that requirement. Similar to laboratory, reimbursement for imaging is being cut by anywhere from 12 to 21%. And once again, we know that the push towards bundled payments and capitation will create further cost pressures on our health system to be able to, again, reduce costs, but let's do it smart, as I keep saying, by getting rid of things that aren't helping our patients. Finally, similar to laboratory, at some point, hospital systems are going to start to realize that imaging is moving from a revenue center, meaning more imaging means more revenue, to it's going to be a cost center under capitation, and we need to be focusing today on just appropriate use of imaging, not overuse or underuse. So in this next section, if our goal is to promote high-value care, and we're going to be targeting sources of low-value care, let's talk about what drives overuse in the first place, because my contention is if we understand better what drives overuse, we'll create better tools to manage overuse and move towards high-value care. So the semi-rhetorical question is, what's the most expensive healthcare technology? And the answer used to be the physician's pen. I guess today we'd say it's the physician's mouse. Whether we realize it or not as physicians, we do drive the majority of healthcare spending. By some estimates, up to 80% of all healthcare decisions are made by physicians. And again, not in any way to malign physicians, but just to say from an ownership standpoint, from a organizational standpoint, we have to involve physicians at every particular step in high-value care. So what I want to start with is reviewing 2 studies that are similar in that they both came from the AMA's registry of physicians who were randomly selected. The first study, published in 2013, asked physicians what they thought were the major drivers of costs in the healthcare system. Perhaps not surprisingly, the number one driver for costs, in physicians' opinion, was trial lawyers, followed by insurance companies, drug companies, health systems, patients, and government. Actually, physicians place themselves seventh in terms of drivers for costs. There also were some notes in this study that show the conflict the physicians have in that we all feel responsibilities to control costs, but we also feel a duty to our patients to do whatever it takes to improve their care. The second study looked at physicians' attitudes about overuse, specifically asking them what they thought were the main drivers for overuse. Here again, the number one answer was fear of malpractice. Number two was patient requests. And number three was difficulty accessing prior records. And on number three, I would certainly attest many emergency room doctors have told me that they do imaging studies, for example, because they don't have access to prior results. In terms of solutions for overuse, physicians really pointed to the future, that is to training, and noted that there needed to be more training on appropriateness of care for our residents. We need more practice guidelines, and then, of course, we need to have better connectivity for access to records as well. All in all, physicians did acknowledge that perhaps as much as 15 to 30% of care was unnecessary, and they ranked it primarily tests greater than medications, greater than procedures. Moving on, let's look beyond physicians as to other persons within the environment that may be involved in driving overuse decisions. This is an interesting study that was done at a large academic medical center looking at attitudes about daily testing. And essentially, they were given surveys trying to see agreement with statements that supported daily testing. Patients should have daily testing. Daily lab testing generally enhances safety and avoids malpractice. What they found when given this survey, the group that most strongly agreed with daily testing were nurses, followed by advanced practice providers, then followed by residents, and who least agreed with that were the attendings. There was one reverse question, which is I would be comfortable with less testing, and the order reversed. Attendings agreed most likely with less testing, followed by residents, APPs, and then nurses. The interesting thing within the discussion here is that when the team members, the nurses, the advanced practice providers, and residents were asked, why do you favor daily testing, they mentioned that they thought their attendings actually wanted it. So at the bottom, as I said here, is misperceptions of the attendings' belief may drive unnecessary testing. The solution could be as simple as let's just talk as a team as to what are the goals and objectives for daily testing. The final survey that we'll talk about dealt with another very important team member, and that is the attitudes of patients. Remember that physicians, on a couple of surveys, it said that it's patients that drive overutilization. This survey might counter that somewhat. So this survey was done at the University of Michigan. They surveyed 2,000 adults who were older between age 50 and 80 and asked them a question about overuse of medications, tests, or procedures among healthcare providers. Interestingly, over 50% said that they felt that there was overuse, or agreed with the statement that there was overuse of medications, tests, and procedures. 25% said in the case of their specific provider, they felt that there was overuse. And 17%, when asked, can you cite an example within the last 12 months, said yes, they could. So again, interestingly, it would seem that patients, particularly seniors, are aware of overuse on a fairly large basis, both generally as well as specifically. Seniors were also asked when it comes to medical treatment if they thought that more is usually better, and what you can see is very few agreed with that statement. In fact, it was only 14%. Finally, 9% also could cite or recall a specific example when they came to a physician asking about a test or treatment, and yet the physician talked them out of that particular decision. The discussion at the bottom here says, again, communication is the key, that older adults, in fact, may accept efforts to avoid overuse of low-value healthcare services if healthcare providers, in fact, take the time to have the conversations. So what I'm showing here is sort of a pattern where, in many cases, simply the conversation among team members to include patients may be one of the solutions to reduce overuse. So to summarize this section, we talked about 4 surveys looking at a variety of actors that may impact overutilization, but I would make a more comprehensive list and put it here as to the global reasons for overuse. On this list, we certainly list the inertia of clinical practice, which means however you were trained as a medical student resident is likely to continue throughout your entire clinical career. Also shows the importance why we need to get to residents and medical students early to treat them or to teach them about appropriate utilization. I've mentioned several times that physicians list as their number one concern medical legal concerns, which is, again, I think it's very real in their mind, although it may not be as significant as they think. A recently well-done study looking at the difference in, for example, resource utilization in military patients that were either treated within a military hospital where there is no malpractice and the same patients treated at a civilian hospital where they can sue for malpractice showed only about a 5% difference. So again, that's a number I would probably quote, about a 5% difference. Patient-driven expectations, we talked about that, but patients are also very open to conversations with physicians. Access to prior test results, we mentioned that. Care team dynamics, we mentioned that. Remember that, again, depending on your comfort level or your expertise, so goes your comfort level with daily testing. Misalignment of incentives, of course, is the impact of fee-for-service, which in many ways is starting to wane with capitation. I love this particular term, the thoughtless ease of testing. Just means it's so darn easy to check on a order set when a patient is admitted, daily CBC, daily BMP, etc. But I think what we need to focus on and think about is purely knowledge gaps. I've mentioned before in other lectures that there's 4 blood products, and we need to focus on improving the use of those, and I think we are getting better. When we talk about laboratory testing, the average inpatient laboratory panel can be up to 1,500 tests or more, 1,500 tests, and the reality is there's just no way any physician could possibly know the appropriate use of all of those tests, particularly when we look at testing being many times stepwise. Based upon this test, we then do this test. Primary care physicians, in fact, do admit to some uncertainty in ordering diagnostic tests, perhaps in up to 15% of patient encounters. And again, this just goes back to the fact that education, providing information to our physicians in a non-judgmental and supportive way, particularly if we can do it at the point of care, has got to be one of the solutions as well.